To do a quick introduction on myself, my name is Ariana, and I'm the Marketing and Communications Manager with Team Select Home Care. And I've also really been a huge portion of TOUGH when we tried to kick it off a few years ago when we started this advocacy campaign. So it's something that's near and dear to my heart, and I love working with Bill. We work very closely together. So really quick, I will also say throughout the presentation in today's webinar, if you want to insert your questions into the chat before we get into the Q&A section, feel free, please. If Bill is talking about a state or a program that you have a question on, go ahead and just type your question as you have it top of head. And then when we start the Q&A section, we'll make sure to get to that question. So don't feel like you have to wait for that portion of today's webinar. If you have the question, go ahead, throw it in the chat, and we'll try to scroll up as we get to that section today. So thank you guys all for being here for our first ever Unforgotten Families webinar, What's Next? Legislative Updates for Family CNAs. Through this webinar, it's our hope that we educate our medically fragile families across the nation on what is happening legislatively. We hope to build community and be a resource for those needing assistance. And we can't wait to continue this monthly series to help all of you. And again, feedback is welcome at the end of this webinar. If you say, hey, next month, I really want to hear about personal care services, or we're getting a lot of questions on a topic we quite can't cover today, we'll make sure that we can cover that next month in the months to come. I will now pass this section of our webinar off to a man who needs very little introduction and whom some of you have probably already spoken with. Team Select's Vice President of Government Relations, Bill. Bill has been with Team Select for over 6 years now and has a plethora of knowledge in the home health legislative space, working with lobbyists, state representatives, members of Congress. So whether you want to take yourself off mute and give him a round of applause, or just type in the chat, woohoo, I will now welcome Bill. So thank you guys.
Thank you, Ariana, and welcome everybody. And good morning, good afternoon, everyone. When I first brought this idea to our marketing department, it was because I speak with so many families each month asking me the same question: when is this program coming to my state, and how can I care for my loved one in the meantime? I appreciate the opportunity to update everyone on Family CNA Program as it evolves in several states, and to give some updates on a federal level, both from CMS and legislative side. A quick introduction about myself: I'm Bill Sczepanski. I am the Vice President of Government Relations for Team Select Home Care. Team Select currently provides Family CNA, or Certified Nursing Assistant Program, and private duty nursing services in 10 states in over 36 locations. I've been in the home care industry for nearly 20 years now, spending most of my time as an administrator of PDN, or private duty nursing agencies. I've been with Team Select Family for over 6 years now, and spent the last 5 years of working on Family CNA model to bring it to more families and more states nationwide. So far, we have successfully added this model to several states and written legislation in several states to add this model. We want to open up this webinar to your questions about Family CNA Program, how it works, how you can try to bring this to your state, and also who you could contact in your local government to add this program to your state covered benefits.
Thank you so much, Bill, and kudos to you for all the work you're doing to help medically complex and medically fragile families through this program. I know we've worked a lot together, and you have just been such an immense help to me, your team members, and your families everywhere. I mean, we talked to families from New York to California to the dad in Florida, and every time you're just such a wealth of knowledge. So we're going to go ahead and segue into the general program update here in a minute, on where Bill will go over what states the program is currently in, what legislative changes we have coming that may make a difference for families in need, or some of you families even on the call today. After that, then we'll dive into the Q&A portion of today. So I do want to note just once more, if you have any questions, I see Victoria has already done a fantastic job at entering her question in the chat for Bill. Feel free to continue doing so, and I'll make sure when we get to Q&A that I moderate those appropriately for Bill. So, all right, Bill, I'm going to go ahead and kick it off to you and take it away.
All right, great. Well, as you see, we're going to cover here this map that you have in front of you currently right now. I will review the states that allow for Family CNA or Home Health Aid Program on this slide. Please remember each state calls this program something differently just because it depends on what they call an aid in that state. So here in Arizona, where I'm from, they call it a licensed health aid. In Colorado, it's called a CNA or certified nursing assistant. In Massachusetts, they call it a complex care assistant. So just remember, it, they're all aids, so it's just all potatoes. I just always like to say that because I use home health aid, CNA, LNA kind of interchangeably all the time when we talk about this model. For our discussion, the Family CNA program is mainly for those who are qualifying for private duty nursing. These individuals have mild to moderate acuity needs. So what does that mean? That means individuals who usually have some sort of, they're already qualified for private duty nursing through their Medicaid system. They have a feeding tube to up to mild to moderate trach care needs. This model is usually not utilized for those who have ventilator care. So for those who need ventilator care, a nurse is still needed to care for that individual. And so, but the goal of this program is to utilizing family members and parents as paid caregivers. You could take those nurses who are working those lower to moderate acuity cases and have them work to the higher end of their license with those individuals who have ventilators and be able to care for them and get them their staffing that they need. The Family CNA program allows a family member to be a paid caregiver, including a parent of a minor child. We utilize either RN delegation of skilled tasks or through the scope or through their scope of practice of their discipline, depending on the states, how it's set up, in order to be able to provide tasks as an aid, like tube feedings, medications, etc. Delegation tasks or tasks that they're allowed to do under their scope of discipline depends on the state. So it'll vary each state. With the end of the PHE or public health emergency, many states that allow many parents to provide personal care or attendant care during the PHE. And many states are now making that a permanent part of their programs under waivers like 1115 waiver, which is what's called a demonstration waiver with CMS. And CMS is the Center for Medicare and Medicaid Services. There's also a home and community-based waiver called 1915C, and also an HEBS state plan called a 1915K. Where those are allowed permanently for parents to be paid caregivers, even to minor children. Those are mostly for personal care or attendant services, and we're going to be focusing more on the private duty and not on the personal care today, just so everybody's kind of clear what population that we're going to be talking about today. The following states have a fully active CNA program, so I'm just going to go through these states very quickly just to kind of give a summary of each state. So Colorado is the original. It started in 1999. The parents there called the program a Parent CNA Program. If you ask Medicaid, the official name of the program is the CNA Home Health Benefit. It's a per visit model. So when I say visit, and then I'll talk about hourly care. A visit means care. Typically, most states define up to 2 hours of care in one setting. Some states will allow you to stack those visits. Some just will only give you so many visits per day. It just depends on the state. And then the other type of care model is, of course, an hourly model. So 8 hours, 10 hours, 12 hours a day. In Colorado, they can delegate tube feedings only currently in Colorado under that model. In New Hampshire, it's been established well over 15 years ago. called the Family LNA, or Licensed Nursing Assistant Program. It's under the Licensed Home Health Aide benefit. It is a per visit model and can delegate to fees. And the legislature and governor actually just signed allowing medications to also be delegated to aides as well. In Arizona, they established a program in April of last year called the Family Licensed Health Aide Program, or LHA. It is a per visit model. They can delegate to feedings, trach care, and medications. Next is Pennsylvania. This was established during the PHE, or public health emergency for COVID, called the Family Home Health Aide Program. This is an hourly model. Currently in Pennsylvania, there's no allowance for delegation of any skilled tasks. It's only activities of daily living only, or unskilled care currently right now. In Indiana, also established during the public health emergency, called the Family Home Health Aide Program. This is a per visit model. They can delegate to feedings only. That actually was just approved by the legislature and governor this year during their legislative session. There's also a personal care, attendant care aspect of this under their A&D, or adult and disabled, and what they call TBI, or traumatic brain injury waiver. These are home and community-based waivers. This is allowed under attendant care, but is an hourly care service and cannot delegate any skilled tasks because of its of an attendant care. There's no clinical oversight. In California, we actually don't have the official date when this program started there. They have a modified program there called the Family Certified Home Health Aide Program. This is an hourly service. It is under the HGBA waiver, which is a home and community-based waiver. Unfortunately, right now, delegation is not allowed for skilled tasks. So again, it is kind of like Pennsylvania's only activities of daily living or unskilled tasks currently right now that are allowed under this program. And the next is Massachusetts. They are kind of the new kids on the block. They started in July of this year. Their program is called the Complex Care Assistant. This is an hourly service, and they can only delegate feeding tubes at this time currently. The next I just wanted to kind of talk about is legislation. So you will see that in the gray there on the map. These next states are ones we've been working through legislatively to add this program, and then they're in the process of implementing this program in many of these states. So the first one we're going to talk about is Florida. This program was approved by the Florida legislature and the governor in June of this year. It is called the Family Home Health Aide for Medically Fragile Children Program. Anticipation start date is probably July 2024. Again, this is just an estimate, but we're thinking probably by July of next year. With this legislation, they will be, an aide will be able to be delegate skilled tasks and be able to do tube feedings, trach care, and medications. The next is New Jersey. They approved, their legislature and governor approved this in July of this year. It is going to be called the Family Home Health Aide Program. Again, anticipation of start date at the latest by July of next year. Can delegate tube feedings, trach care, and medications. Next is going to be Montana, approved by the Montana legislature and signed by the governor in May of this year. It is called the Pediatric Complex Care Assistant Program, anticipated to possibly to start by the July of 2024. I know there's a lot of work going on, but hopefully maybe try to start it by the beginning of this year, this coming year. Can delegate tube feedings, trach care, and medications so far. Next is Maine. They approved via their legislature and also signed by the governor in July of this year, the Family Home Health Aid Program. Again, we anticipate to start probably by July of next year. We're not sure currently right now what task will be allowed to be delegated to a home health aide. So that's still to be determined. The next thing I want to mention is Oregon. Now, Oregon is just allowed through a personal care program through a 1915K state plan under home and community-based services. They're allowing for this personal care program. It's going to have a limited number of spots, so it'll be interesting kind of to watch how will be implemented in Oregon. There won't be any delegation of skill tasks since it's going to be a personal care program, so there'll be no clinical oversight by an agency. And then the last state is Washington State. They approved a study. The legislature and governor approved this in May of this year. The study is to look at the viability of the program and how the program could work there in Washington State. It will be conducted by Washington State Medicaid, and the findings are due back into the legislature and the governor by the end of this year. And then, as you currently see, there are several pink states there colored on the map. These are states that we're working on. So they include New Mexico, Texas, Wisconsin, Illinois, Virginia, Idaho, North Carolina, South Carolina, New York, and Connecticut. You may not see your state there. It might be one of the states that are in white. When we kind of started out with bringing this program outside of just Colorado, we just started with the states that honestly we were already in. And then from there, we've had so many families contact us. That's why we've added these different other states that are in pink as well. So if you are interested and you're one of the states that are in white, feel free to reach out to me, and we can definitely talk about what is needed in your state and what that would look like and the different type of efforts that would go into that to try to bring it to your state. And then lastly, just want to speak about one of the questions I always get is, Bill, what does CMS say about all this? Which is always a really good question to ask. And so on June 6th this year, CMS had an all-state Medicaid meeting and CHIP call with their states, where they talked about how states can allow parents to be paid caregivers. They talked about the 1115 waiver. They also talked about the different waivers in home and community-based services, the 1915C, 1915K, that states can utilize, also a home health benefit. So I actually have a link to the actual PowerPoint that they went over with states that we'll put in the chat so that you may be able to review that. But that just gives you an idea of what CMS is saying about this program, and also encouraging states to allow this for their state. CMS can't mandate states to do this. This is up to the states if they want to take that recommendation and run with it. But we're going to put that in the chat there for you. And Ariana, I'll turn it back over to you.
Awesome. Wonderful. Thank you, Bill. Now we're going to head into the Q&A section of today's webinar, which I'm hoping is a little bit more conversational. So I will give everyone just about a minute to insert their questions into the chat. If you do wish to verbally ask it, you can go ahead and use the raise hand button on Teams, and we'll kind of bounce between each. If you need to get up to use the restroom really quick, let the dog out, wherever you are on today's call, feel free to do so. Just give everyone about 45 seconds to a minute to type those in or raise your hand. Thank you, guys. And thank you for putting that PowerPoint in the chat, Bill. One thing I do want to mention to all of our attendees on today's call is that after this call, I will work to put together an email to everyone who registered for today's event, which will include some things that we went over, possible images from the PowerPoint that we're sharing here today, And again, the recorded version, or again, some of the links that Bill sends, like the CMS, PowerPoint, and so on. So in case you think you missed anything on today's call, hopefully we'll be able to cover that in our follow-up email before end of day Friday. So I'll go ahead and kick us off, Bill, with one of the questions in the chat. I know you touched on it lightly, but can you go a little bit more in depth on the status for Colorado for Berna and Elliot on today's call?
The status, I'm sorry, can you repeat that?
The status in Colorado. I know currently they have the Family CNA program, but wondering if you can go a little bit more in depth.
Sure, absolutely. So in Colorado, the model there has been set up since 1999. They allow for the parent CNA program. There's also what is called the IHSS program. That is a consumer directed program. It's what we call agency based. So the agency is still involved. The agency takes care of payroll and HR. They don't have any clinical oversight. And in this model, it is delegation is waived. So parents are allowed to be able to provide any type of care to their child. This model is being changed actually from the IHSS is being moved into a 1915K model. And why that's important, instead of being under a 1915C, I'm going to get real technical here for a second, but bear with me, is because the 1915K is actually, a lot of people will say it's a waiver. It's actually not a waiver. It's a state plan, even though it's under HCBS. And as a state plan, it's an entitlement. And so what that means is there won't be a wait list. So a 1915C is a waiver, so there could be wait lists to keep the state can have a wait list and only allow so many people on to that waiver at one time. Under this K waiver, which would start in 2025, there wouldn't be a wait list. It would be an entitlement, which means it would be able to serve more individuals, which is always good. Also under a K waiver, the reimbursement the state gets federally is actually increased by 6%. So that's also a kind of extra nice caveat for the state in regards to funding for the program. So that's currently what's going on with the model currently in Colorado. It's not only for those who qualify for private duty nursing, but those who also have other disabilities. Maybe their skill level is not as severe, but they still have needs with assistance for like activities of daily living and things like that.
Wonderful. Thank you, Bill. And they just entered one additional question, more specifically for the 1115 extension for continued parental leave and other services ending this November. Do you have anything to add to that or knowledge to share?
So there are states, I'm not sure especially on Colorado on the 115, there are states that are using the 1115 waiver. That's when we say 1115 waiver is basically let's say what the CMS calls a temporary waiver. And so, for example, here in Arizona, where under Arizona Medicaid, they were allowing parents to provide attendant care services. They're actually making that permanent by putting it under a 1115 waiver. So that usually gives states time to then convert that into a permanent waiver, because that's good for at least 5 years until the state has to renew with CMS. So you do see a lot of 1115s happening right now. So the states kind of get a little bit of, they can take care of the families and then get a little bit of a breather and figure out where they want to put this this program permanently within their benefit structure, or if they need to create apply for a different waiver.
Perfect. And we can also share some resources in our recap email as well for some of these questions. So now I'm going to give it to Victoria. I'm going to let you unmute yourself, Victoria. I see you have your hand up, and go ahead and ask Bill a question regarding the programs.
Hey, Bill, it's Victoria. How you doing?
Good. How are you?
Good. Hey, just some clarity on some things. I know with you and I working together to try to figure out these different programs, I think it's important to point out that the Parent CNA program in Colorado, like, for example, my 3 children are on that program. Medically, they qualify, but they are not on any type of tech. And some of these programs, like the one in New Hampshire, and I believe the one in Arizona, unless that has changed, you have to have a tech-dependent child in order to qualify for that program. So some of these programs are like Parent CNA, where my kids don't have to be tech-dependent to be able to receive that care, but other states do. And it's just been really hard for me to be able to separate out which states, you know, HHA, you still have to have a tech kid. HHA, you don't have to have a tech kid, things like that. So could you clarify more on those states that are already working?
Sure. So yeah, that is a really good point. A lot of the states that we went over today, you have to qualify for some type of skill need or technical need, technical care, like a feeding tube, trach, etc. And the reason for that is because, like Colorado, it started out with that population first, and then it's in Colorado they went eventually over time expanded it. I always like to tell the story about Colorado because it really gives you an idea that this sometimes takes a little bit to expand the scope of it if the state wants to do that. But this started with one mom in Colorado. There was one mom who was a CNA, and she wasn't getting care at the time. There was no staff available. So she asked if she could be the paid caregiver. At the time, Medicaid said no, and there was a rule against it. She asked for the rule. No one was able to ever give her a rule because there wasn't any rule against it. And so she went ahead and appealed it and won the appeal, and was allowed to go ahead and be a paid caregiver. And it literally started with one mom, and then they added another parent, and then another family, and another family. So it just kind of slowly started out, and then with Colorado. But there are states, for example, to answer your question, like Indiana, that do allow for the individual doesn't have to be qualified for private duty nursing. They can get attendant care, personal care services. Same with Pennsylvania is one of them. California is one of them. So it's one of those things when you're looking at this model for your state is you really have to kind of look and see specifics of what they allow and don't allow. Sometimes if it is a waiver, so if it's a home and community-based services waiver, you can look up their application online. It is actually listed online to where they submit it into CMS. And it is a 300-page document. It may take you a little bit to look over this, but it can tell you in there kind of what they allow and don't allow as well. That's in there. So those are some of the things as well. But yeah, most of the states right now that we're dealing with, it's starting out with the private duty population first, but there are some states that are ready that are looking at trying to expand that. And then there are sometimes states that want to just expand it from the get-go. So this depends on the state.
Wonderful. Thank you, Bill. I will go ahead and read you. We have 2 questions from Megan Bowser, Family Voices. I think it says Colorado. I'm going to read you 2 questions, okay? So the first one is, do you have any data about IHSS programs that allow parent providers? And then the second one she mentioned was information about caps on numbers of hours in different states.
Very good question. So let me go first with IHSS. I don't have any data in regards to IHSS. One of the difficulties with getting just having data, period. I know if there's other agency providers on here, they're going to laugh when I talk about data. Getting data is actually very hard from a lot of Medicaid systems. So the data that we have, that sometimes that I will show in our presentations, is our own data, and it's based off our own clients that we have, because getting data from states is usually difficult to do. A lot of them don't have always the capabilities or the funding to be able to give that data out there. What was the second question, Ariana?
It was about caps on number of hours allowed in different states.
Okay. Yeah, so in some states there are caps of how much an individual can be able to provide care. Like here in Arizona, it's 40 hours per person, not of the client, but per person. Also in Florida, it's theirs is going to be 40 hours as well. But then, there's other states like Colorado where there isn't a cap. There also is not a cap either on how many people we train for this program. So one of the great things about this model, when it's been set up correctly, is making sure that the agencies are paying for the parents' training or the family members' training to be an aide. Not in all states that I mentioned is that required. But like, for example, in New Hampshire, that's not required. But like our company, we pay for the training. Same in like Pennsylvania, we pay for the training. And so the reason why that's so important is because obviously parents, a lot of parents don't have the actual funds to be able to pay for this training. So we pay for it, and it's an investment in our clients and also in our business by doing it. So
wonderful, thank you. I'm going to go ahead and kick it off to Leslie, who has her hand up. Leslie, if you can go ahead and unmute yourself and see how we can answer your questions today.
Yeah, thank you very much. So hi,
Bill. Leslie.
Good to see you.
Yeah.
Hi. Hey. So maybe this is too big of a question, and maybe you want to think about it and email me, but I'm going to ask it anyway. And if you had to because you're such a repository of knowledge on what all the states are doing, and since we're working in the feasibility realm right now, if you had to take the best of the best from the states and what you've learned and what you like and what you think is most successful in all, what kind of things would you pick that are sort of best practice in putting this together? And feel free to say you're going to email me, because I know that's a big question.
Wow, yeah, no, that's a really good question, Leslie. I think it's probably a combination of a lot of states. I think that the more that a state allows a parent or family member tasks that they can do as an aide, a CNA, home health aide, complex care system, whatever it's called, is better. I'm always a little resistant on ventilator care, but for example, in Montana, they're not only including medications and feedings and trach care, but even some IV care. And I know sometimes there's a hesitancy with some individuals with Medicaid system legislators saying, "Wait a minute, you're going to allow that for an aide to do that." But you have to remember, the parents are already doing this. And so what it really comes down to is this program not only is being able to give the families the staffing they need, but also the training and explanation of why we do what we do. So many times as an administrator, I have seen parents, they know how to do the skill, but they're just robots and they don't understand why we wear gloves and they don't know when we need to call. What temperature do I need to call if they got a fever? When is that important? Things like that. And so that education piece is so critical. So I think that if the state would allow it to allow them to do more skills in the home, because unfortunately with the nursing shortage, it's not going to get better anytime soon. And when I say anytime soon, I'm thinking at least the next decade, if not longer. And so I think having that, making sure too that we as agencies are able to pay parents and family members a livable wage. And that means different things in different parts of this country. But making sure that we're paying the families livable wages. And so that requires agencies to have healthy reimbursements to do this. But again, it's a cost savings to the state because not only you're typically paying an aide and reimbursement less than a nurse, the hospitalization rate we see with this population goes down drastically. So in our population, we see it anywhere from 8 to 12%. For our normal PDN agency in Colorado, it's anywhere from 0.3% to 0.6% on a monthly basis. So at $4,200 a pop, typically on average, is the daily bed rate for a child to be in the hospital in this country. It's great savings to the state. And then the other thing as well as making sure. I just actually forgot my thought there, but I would say making sure that we there's a good range of scope of either delegated tasks that is allowed or is available under that scope of practice for that aid in that state and livable wage and having those available is probably the most ideal circumstances. And then at the end of the day, this is up to the family if they would like to be in this model or not. And then also making sure that it's open to not only family members and parents, but also family friends. I live here in Arizona. I'm actually originally from St. Louis. I had a medically fragile child and I needed this program. I wanted to be able to utilize it because I have no family here in Arizona. The model here in Arizona has to be a family member. So not being able to utilize a family friend kind of put me up a creek. So that's important as well, as making sure that it's up to the parents who they want in their home. And then for us as an agency to go ahead and train them and get them qualified.
That's a great response, Bill. I think just accessibility overall. So I really appreciate that response. Absolutely. I'm going to go ahead and read a question written by Christina. I think I know what she's asking. So let's try to take it away. So she's trying to fill the gap between PCS, personal care services, or PAS in Pennsylvania, personal assistant services, and PDN. So she's asking, would a state need to first extend personal care for paid family caregivers and also add something about delegation? She says, how do you get to delegating skilled tasks and what authority should be used in that manner?
So no, very good question. So under personal care services, yes. With personal care services, if your state has personal care services under a state plan, then because if it's under a state plan, there is a lovely rule under CMS called 1905 A of the Social Security Act that prohibits a parent, spouse, or guardian from being a paid caregiver. And so it will not allow a parent to be a paid caregiver under that. That's why in a lot of states you saw after the PHE was over, they revert back and said, parent can be a paid caregiver, excuse me, for personal care or community care services. If you had a waiver, it could be allowed under a waiver. Some states had a waiver. So if you, like most states, had a state plan, then they moved to an 1115 waiver or demonstration waiver. They put them under that waiver temporarily, even though it could be up to 5 years. So first, yes, you would have to get under a waiver like that, like 1115 or a 1915C or 1915 K, for example. Then what was the other question? I'm sorry, Ariana.
It's talking about once she gets there, how does she go about delegating skilled tasks and delegation?
So you won't be able to delegate skilled tasks under personal care because there's no clinical oversight. The only time that you do delegation of skilled tasks is more when you're talking about the Family CNA model with private duty nursing. So because we're still going to have clinical oversight, which means there's going to be an RN supervisor. They're going to be opening your case. They're going to be doing a plan of care. The tasks that you would give to your child, even as an aide, will be based off of the plan of care that is signed off by a doctor. So that is the difference between the Family CNA model and private duty compared to just straight personal care. Personal care is going to be more your unskilled or activities of daily living compared to your skilled care, which is a feeding to trade care, medications, things like that.
Perfect. Thank you, Bill. So we have another question, which I'll ask from the chat. And then after that, we'll go to someone that has their hand up. So Charlene wrote that he or she is in Pennsylvania,
Okay.
and they want to know about parents. So it would be an elderly adult, and how do the parents apply for this benefit, or do they under the family HHA in Pennsylvania? So they're asking, do they contact their Medicaid insurance? Is there a department? And how do we go about that?
The best thing I would tell you is contact your, if you already have a home care provider, is to contact them and speak with them, and they can help you through the process. If you don't have a home care provider and you are, you can contact your Medicaid MCO or managed care organization there in Pennsylvania. They're the case manager that's assigned to your case, and speak with them, and they should be able to help you through the process and get you set up with some possible home care agencies who can go ahead and take you through the process.
Wonderful. Thank you, Bill. I will go ahead, and I know we have about, I want to say 15 minutes left. So we'll just do a few more questions if we can, Bill. We have Shasta Kearns, and I can't read the rest of the name. I sincerely apologize.
Oh, hi, Shasta.
Why don't you go ahead and unmute yourself, and we'll see how to best answer your question.
Hi, thank you so much for hosting this webinar. I'm sorry if I was late with caregiving responsibilities, so I don't know if you covered this in the beginning, but here in Oregon, a big problem that we're having is this kind of bizarro world around the funding for it. These hours exist, and we could hire anybody to do them tomorrow, but there is nobody to hire. And so we're talking about a program where we would actually use the hours. They say, oh, we can't afford it. So what we've gotten is a lot of questions from legislators saying, well, how have other states afforded this? How are they doing it? And I don't really have a good answer for them. So do you have an answer?
Yes, I mean, for the private duty population, it is, if you compare what an aide is reimbursed to, I'm not talking about what an aide is paid, but what an aide is reimbursed to an agency like ourselves, compared to what an LPN or RN, which usually is different, the rates are usually different in most states, is paid to an agency. It is less for an aide. And so there's a cost savings there. But the real cost savings is us being able to keep children out of the hospital and avoid needless hospitalizations. And so that's the real cost savings. So I try to always explain to the state, yes, the hourly cost savings is important, but the real thing that you're looking at is that back end of what we're paying for hospitalizations. So that is the cost savings. Um, you know, anytime a medically fragile child, especially consistency is very important. And so the more that we have consistent staffing on a case, in order to make sure that child's getting their meds when they're supposed to, they're getting the treatments when they're supposed to. It's been shown in many different studies that it saves money because that way the child is getting what they're supposed to be getting. They're not being thrown off their schedule. And by doing that, it keeps them out of the hospital. So that's usually where the cost savings is. It is kind of hard to always thread that needle in states. I have that challenge sometimes in states. And what you're facing there in Oregon is sometimes a challenge where you'll have a program set up, but it's an unfunded mandate. So it'll get set up, but there's no money attached to it. So that's always the challenge when having to go legislatively and do this is you have to make sure, is there money attached? Is there funding that's attached?
But like literally, sure how are legislators budgeting for this? Are they taking it out of the existing waivers? Or
they're usually using, the existing waivers and that, and also too, a lot of times in for both personal care and for private duty nursing, there's money sitting there already that has not been, it's been allocated but hasn't been used because there's nobody to staff the case. So they a lot of times do have extra funding there that's not really being utilized. Now states have to utilize their money every single year. They can't roll it over. But there's also sometimes money that's not being used as it's allocated. So it's good to sometimes be able to have like legislative budget office in your state kind of take a deep dive and look at, how much is being utilized. I know there was a question about data. That's a good question of, how much of the authorized hours in your state that are being authorized for children, how much is actually being utilized? And it's amazing to see that. And that's where we're able to show the states saying, hey, look, you're not actually even using all the money that's allocated. So let's try this model so that we can do that. And in some states, sometimes they like to pilot it as well. So where you may not go into a full-blown program, you may start out with 30, 50 individuals and try it out from there as well.
Okay. All right, thank you. But there's no like studies or reports that you're aware of on the cost benefits?
There, Dr. Carolyn Foster has done some studies. She's from Lori Children's. She has done some studies. I believe her last study did talk about some financial. I can't remember right off the bat, but I do believe it talked about some financial implications.
I'll check in with her. Thank you.
Okay, yeah.
Thank you, guys. We'll do one more question, and then if there's any questions we didn't get to today, I do want to clarify that Bill and I will be working together to make sure that we are connecting with you guys offline after this call to build and strengthen those relationships and also help assist you in whatever you need, whether that be for your organization, your family, your loved one, or just get some answers in general. So if we don't get to them on today's call, we will try to connect one-on-one or reach out. And again, just want to mention before we answer that last question, this recording of today's webinar will be live on our YouTube channel and included in the recap email to everyone who registered. So if you have a friend who registered who wasn't able to attend today, they will also get that recap email. So Bill, I'm going to scroll up here just because this individual asked it a while ago. Megan is asking about language accessibility in Colorado and that the CNA licensing skills test specifically is only in English. Do you know if this is an issue in other states, or have you heard anything talks about making this test more accessible?
I know that federally there is a requirement that if there's a majority, I believe it's the majority of language spoken in a state, they have to offer it, for example, like Spanish, and that's in a state. So I believe states have to offer those trainings, and also brochures and paperwork and things like that. And that again, it depends on, I've seen different things in different states. Some states are very good with that. Some states it's a challenge. I think everybody on this call would probably agree with that. There's a lot of things that states are supposed to do, but sometimes always, getting those done it doesn't always happen. So it just depends on the state. But from my knowledge is that, again, if there is a good amount or majority there in a state, they have to offer it. In that, if you are looking for classes there in Colorado, I would talk to some of the agencies. They should be able to assist you, or also talk with your Medicaid case manager. They should be able to assist you with finding classes that are in different languages.
Perfect. Thank you, Bill. And apologies that we weren't able to get to everyone's questions today. But again, we will be recapping in an email and also make sure we connect one-on-one offline. So thank you all for tuning in today and for supporting the Unforgotten Families to continue our mission and being the voice, advocate, and champion of medically fragile children and their families. The work that Bill does and all of you on today's call, whether that be for your loved ones, right? Your caregiver for your child. You work for an organization that helps advocate. Thank you, because it truly does take a tribe. It takes a community. It takes a group. It's not just one person. The questions today were absolutely fantastic. You guys are full of knowledge yourselves, and so is Bill. So again, we'll make sure that we connect after today's call. Don't forget to follow us on all platforms if you haven't done so. And again, just one more time, this recording will be on our YouTube and emailed out. So thank you for supporting TUF. Thank you for supporting your local communities and everything that you're doing and your loved ones. Bill, is there anything you want to close out this webinar with for any final words?
I just want to thank everybody for their time today. I really appreciate it. This model that we discussed today, especially for the private duty side, it's not the be all say all to resolve every issue that comes to private duty, but it definitely is a start and it helps a lot of families. And please feel free to reach out. And if I don't know the answer to your question, I'll definitely find somebody who does and get you in touch with them.
Yeah, awesome. Thank you, guys. I hope you have a wonderful rest of your Wednesday, rest of your week, and a really good weekend when we get to that Friday afternoon. So thank you, guys.